Oh, it's fine.
Okay. Okay. I'll start because I haven't. Introduction. Hey, Steve.
I think we'll give a few minutes to let a couple of people in. Thank you so much, everyone. Thank you, everyone, for joining for this seminar. And I'll pass this over to Jane to introduce our guest speaker today.
Hello, welcome everyone to this beautiful fall day, fall afternoon. I wish Stephen could be here in person, but we're so happy to have him, at least via Zoom. And Dr. Steve Safren is a professor of psychology at the University of Miami, and he directs the UM Center for HIV and Research in Mental Health, or CHARM. This is an NIMH-funded AIDS research center. And his program of research focuses on health behavior change with a particular emphasis on mental health and substance use components of HIV prevention and treatment, both here in the United States and internationally. He himself has developed and tested adherence and combined depression adherence interventions that are being used around the globe. Within HIV prevention, many of his projects investigate social, contextual, and behavioral health issues related to sexual and gender minority populations. He joined the Department of Psychology at the University of Miami in 2015 after 18 years working in the Harvard Medical School system at Mass General Hospital, where he was a professor and director of the Behavioral Med Service. He led behavioral science studies also at Fenway Health while he was there. He has been PI, or protocol chair, of no less than 18 federally funded studies through NIMH, NIDA, and AAID, and he has been continuously funded through the NIH as a PI since 2001. And I think I can add that I have the pleasure of knowing Steve. Personally, I like to think of him as a friend as well as a colleague. And it's public knowledge that I was on the review committee when his K Award is being announced. And it's all confidential, but I can tell you there was a lot of enthusiasm about this young person who had these incredible clinical expertise as well as rigorous methodological training. And I think his K was funded there that first round, or this very second, it should have been, if not the first. And
no, it never was funded, actually. I had to switch it to an R21. So for any junior people out there, persistence pays.
That is a great, oh my God, I should have looked that up before I said that. But
no, and it was this whole program of research. So it's a really good story.
That actually is. Now I'm going to change the story if I ever introduce you again. But I was going to say we had very high hopes. I certainly did, hearing about this. And Steve has fulfilled them all, more than exceeded expectations in so many ways. So I'm thrilled he would take the time to join us today. And I hope you join this presentation. Thank you, Steve.
Thanks so much. Yeah, it's funny looking back at that. And also Chris Gordon was my project officer at the time, but it was his first day. And Diane Rausch did one of those mentored. Chris Gordon is the project officer that Jane and I and a lot of the behavioral scientists have worked with at NIMH. And Diane Rausch was the senior project officer, kind of like doing a joint phone call to give advice as to, how to submit and stuff. So, and I remember thinking his name was Gordon Christopher instead of Christopher Gordon. But anyway, yes, persistence pays. So the committee did not want to fund this project as the first project, which I'll be talking about as a K award, but eventually it got funded as an R21. So thank you. I do wish I were there. Seattle is far, but I love the team at UW, and it's an amazing group. So I'm really honored to have been asked to speak with you today. So the title is Optimizing HIV and Mental Health Outcomes with Cognitive Behavioral Therapy. For those of you that aren't psychologists or mental health professionals, cognitive behavioral therapy is a specific type of treatment usually used for treating mood and anxiety disorders. And it's evidence-based and it's structured, unlike traditional psychotherapy, it's a kind of like half taking a course and half being in therapy, but with skills. It's skills-based and involves reducing symptoms of whichever mental health problem you're having. These are my disclosures. I don't have any industry funding or haven't, but I do get royalties from books, including some that are involved in the treatment or interventions that I'm talking about today. So why are we talking about HIV and mental health and using cognitive behavioral therapy for addressing mental health and HIV? And one reason is that really these are intersecting epidemics. And when we think about things like the 90-90-90 goals, and now they're 95-95 goals as an interim step to just ending HIV as an epidemic, the thing that's going to be the hardest, in my opinion, is going to be those last, 10-10-10 population, or the 5-5-5% that aren't reached by traditional public health messaging or public health interventions. It's how do we get over the hump of the people that really, either due to structural issues, social issues, or mental health issues, or the combination of both, are not able to make the needed behavior change to achieve, in this case, we're talking about HIV treatment outcomes, but also it relates to prevention as well. So there's not a ton of huge epidemiologic studies regarding the prevalence of mental health and HIV. This one, the Bing study that's up on the left, is a bit old, but as you can see, when you look at HIV positive populations compared to this, national estimates for people with across the nation using a similar assessment method, the rates are much higher, especially for depression and dysthymia, which are the depressive disorders. We did a smaller study at Fenway Health, which was just with HIV positive men who have sex with men, similarly seeing high rates of major and other depression. There's other kinds of studies like this one in Philadelphia, where you just do sample studies, but seeing that usually the rates in HIV of mental health issues are greater than general population estimates. The other thing to think about, now everyone sees these different cascade slides all the time, and what we just have to remember about the HIV treatment cascade is that for mental health, these estimates that I just mentioned are really only of the people who are engaged in care, because those estimates are usually done in clinics. So all these people, we don't know the prevalence of mental health problems, but likely the undiagnosed or people that aren't engaged in care and that are diagnosed, I'm sure, I would think that maybe one of the reasons they are not engaged in care has to do with things like comorbid depression. We've done meta-analyses showing that depression and adherence are negatively associated with each other across independent samples, and really consistent finding that depression and adherence are associated. I had mentioned, I'm mostly going to be talking about antiretroviral therapy for treatment, like when you're taking it to treat HIV for yourself. But the HPTN 052 trial was the definitive trial showing that U equals U, that undetectable can't be transmitted to others. And it was with serodiscordant couples. And we did a study looking at predictors of adherence in people that were taking ART early. So at the time, that was before you would be taking, for country-specific guidelines, antiretroviral therapy right away. It was more thought to take antiretroviral therapy when it was clinically needed and your CD4 count dropped. And in that study, when we looked at people who were taking antiretroviral therapy in the trial for the purpose of preventing it to their spouse, the only psychosocial predictor that uniquely predicted non-adherence was increased depression or mental health quality of life. So it's for when you're taking it for your own purposes, or for if you're taking it for, let's say, prevention reasons. Now, when I'm talking about depression, also in the case of the trials that I'm going to talk about in terms of treating depression, we're not just talking about mild or moderate symptoms that might be fleeting and go away. We are talking about major depressive episode or major depressive disorder, which is clinically significant. So you have to have sadness or depressed mood most of the time, more days than not, or persistent loss of interest, like you're not interested in things that you're normally interested in, with a total of 5 symptoms. So 1 of those 2, and then 5 of these other ones. So depression, I mean, think about trying to adhere to your medicines or make behavior changes when you also don't have energy, you don't have concentration, you are suicidal or hopeless, you're not sleeping well, you're feeling excessive worthlessness for most of the day, more days than not. So think about that. And then, you know, public health messaging, oh, you've got to take your pills, or your doctor telling you, oh, you got to take your pills. But it's a little bit more complicated when you're also really struggling with this persistent type and severe, you know, distress. The other thing that I just want to say is when we think about any health behavior change model, depression can interfere with basically all of the different components. So I'm giving the example of the IMB, the Information, Motivation, Behavior, Skills model, but the same kind of graphic basically can be done for every single, like, self-efficacy, you know, theory of reason action, like all the health behavior change models that are out there. If you think about depression, and, you know, I gave the example of depression, but I have here also substance use, or think of like post-traumatic stress disorder or other mental health problems. But in this case, depression, being depressed affects the acquisition of information. It affects having, you know, learning behavioral skills. It affects motivation, and it affects the health behavior itself. I mean, think concentration problems, sadness, suicidality. Like, these things make it harder to have enough of the components of these models to change your behavior. It can also affect the relationship. So you might even have the information, but because you're depressed, you're not going to change anyway, or you're not going to, you know, you might have the skills within you, but again, because of motivation and low depression, you're in high depression. I mean, your behavior isn't going to change. So what about integrating the treatment of depression with, in this case, adherence counseling, with evidence-based approaches to treating depression, that is. So our treatment, I call it a treatment. I'm using the word treatment instead of the word intervention purposely, because cognitive behavioral therapy is a validated treatment for depression. An intervention is more in the way that I'm talking about it, like health behavior change intervention. But treatment is like you are diagnosed with a disorder that is distressing and interfering. And CBT, cognitive behavioral therapy, is a validated treatment that has, I would say, better outcomes than antidepressants if you think about long-term follow-up. So each module in this treatment that we developed includes adherence counseling, and it also has typical cognitive behavioral skills that have been used in other depression treatment studies to alleviate distress. But what we do is we have a psychoed and a motivational interviewing session. We do adherence training following the Life Steps intervention, which is a standalone adherence intervention that I also developed. And then these further modules involve integrating the adherence counseling with these additional components. So behavioral activation in and of itself is a treatment of depression, and it involves getting people to re-engage in activities that they are no longer getting enjoyment from, and relearning how to engage in these activities, and getting mastery again out of feelings of mastery, like competence, that you can be fulfilled in things that used to fulfill you. And it takes time, but it is very effective. One of the components of depression is an absence of having pleasurable experiences, and we teach people how to do that again. we look at adaptive thinking, and we try to do this thing called cognitive restructuring, getting people to think more adaptively about the problems that they're having. With depression, it's a cycle. You think negatively, and then you avoid, and then your problems get worse because you've avoided, because you've been thinking negatively, and then your depression gets worse. So we help people to think more logically and more rationally about the difficulties that they're having. It's not the power of positive thinking. It is realistic thinking. Problem solving, similar thing. If you're depressed, you don't solve problems, you avoid, problems get worse. So we do a specific module on problem solving. We use relaxation training and then maintenance. And again, as much as possible in this particular version of the treatment, things always go back to HIV adherence, thoughts that you have about being HIV positive. A lot of stuff that we see clinically are people that feel really guilty about being HIV infected or stigmatized or, struggling in some kind of way like that. And the cognitive restructuring and the activation and the problem solving come back to center about that and help augment the degree to which you benefit from adherence counseling. So the other thing I'm going to say here, and that will foreshadow some of the studies that I'm going to show, is that we also believe that treating depression lowers the volume on your depressive symptoms. And once you do that, you're more open to adherence interventions. It's not, so I don't believe, and you'll see why, but I don't believe that treating depression by itself is going to improve a person's adherence. I think it will lower the volume enough that the person who has poor adherence can then benefit from whatever adherence intervention you're going to do. But if you just get an adherence intervention and that you have depression, that's going to moderate the degree to which you're going to benefit from the adherence only intervention. Okay, I just explained all that stuff. Life steps. These are the steps. It basically just involves breaking down the problem of adherence into manageable steps. And we always ask in the beginning, we ask people to you open your pills and you look at them in the session, and we'll ask people what goes through your head. And if they say negative thoughts like, oh, I don't want to take my pills, or the first thing I think of is how I'm a bad person, for having HIV. Like, these are the common kinds of things that people might say. We try to then ask, okay, well, what are your reasons that you do want to take these pills? What are your, what do you want to do? And we actually are about to publish, finally, we should have done this a long time ago, a qualitative paper from the counseling in this, but we get really amazing reasons why people do want to stay alive, and their reasons for living. And we try to, in a cognitive restructuring kind of way, when we do these other skills for adherence, we try to get them to purposely think of those positive reasons instead of the old, way of thinking in terms of feeling bad about yourself for having to take pills. So that's a big part of this, but it's also just the basic coming up with a plan and a backup plan for all the different components that involved the behavior of taking your pills every day. So this was the unfunded K award that Jane was talking about that became R. At that point, they didn't have R34, so this was an R21. So it was, I believe it was a 3-year R21. I think they were 3 years at the time. And what we did is we randomized 45 people, retained 43 into a crossover design study where half of the people got the intervention that I just described, CBT-AD, the AD part meaning for adherence and depression. And half the people got a letter to their provider documenting their depression, saying you should still treat depression however you normally would, and that they're in this study. And the control group also got life steps only. So they didn't get the full CBT intervention. And as you see for it was a crossover study, but this is just the time 1 to time 2, pre and post treatment. Adherence, this was using at the time MEMS caps, which open and close whenever you which register anytime you open and close your bottle. We saw adherence go up compared to the control group that only got adherence counseling in the letter. That Hamilton depression ratings went down compared to the control group. And then this clinical global rating of depression, which is used in a lot of psychopharmacology trials, also got better in the CBT group compared to the control group. And then also those who crossed over, like I could show more graphs of how those who crossed over then caught up to the CBT condition, and the CBT condition stayed maintained. We did see longitudinal improvements. We did see longitudinal improvements in viral load, but also it was a crossover design. So eventually people got the intervention. So we can't really say the intervention caused the changes in viral load, which comes later. Okay, so that was study 1. Recruitment was really hard. I learned that it is really hard to recruit people with depression into adherence studies because people with depression do not take a flyer and then call and say, hey, I want to join your depression adherence study. I had a great colleague that was working in a methadone clinic where he said that there was a lot of HIV positive patients, and it would be a great place to do the study. The patients would really benefit from it. Our clinic would really benefit from it. And your research might really be advanced from it. So, I was like, okay, great. And, in the methadone clinic, the patients come every day. So retention will be super easy. Guess what? It was not. So we did this study in methadone clinics, and we ended up having to expand to other substance use and other clinics, but it focused on people that had injection drug use histories and depression and HIV, so triply diagnosed. We were able to eventually recruit enough people to do the study, but it was complicated. And in the short term, so when from baseline to treatment, when the treatment was over after the 12 sessions or 3 months, adherence improved compared to control, and depression also got way better compared to control. However, although the depression gains were maintained, the MEMS-based adherence gains, unfortunately, were not maintained, so that this was no longer a statistically significant difference between the 2 lines there. We did not see viral load differences. We did see this interesting CD4 finding where CD4s were improved more in the treatment condition, which is interesting because there are studies correlating depression over and above antiretroviral therapy use with CD4. So it's interesting that depression gains were maintained and CD4 got better, but we also kind of it wasn't that wouldn't be expected. We weren't expecting to see no viral load differences, but yes, CD4 differences. Also in that study, we found that baseline cocaine use moderated adherence follow-up outcomes. So baseline cocaine use, no other substance use variable moderated outcomes, and it didn't moderate acute outcomes, as you can see in, but it did, this is, baseline 3 months, 6 months. It didn't moderate acute outcomes, but it moderated the follow-up outcomes. So in the CBT-AD condition, those with no baseline substance use really maintained their gains a lot more than people that did have baseline substance use. Both groups got better initially. And then in ETAU, there wasn't a difference. So what do we gain from that? Well, we think even though this was a bulky, from a public health perspective, intervention or treatment, 10 sessions in this, the way it was delivered here, probably this group should have had booster sessions, to maintain their improvements. With my fabulous colleague leading the way, we did a Spanish translation and cultural adaptation of the study on the US-Mexico border. This was an R34, and it was also a 2-arm, kind of like our first study, like a 2-arm feasibility randomized trial, which did find longitudinal effects on electronically monitored adherence, depression, also viral load, not significant, but we also found this interesting effect on CD4 in that study. At acute outcomes, but not follow-up. So I still don't really know what to make of the CD4 findings, but it's interesting that 2 studies found this interesting thing here of CD4 effects in the absence of viral load effects for this intervention. Okay, study 3. So we thought, okay, well, we saw some good effects for the treatment compared to adherence counseling and provider letter only, which is the enhanced treatment as usual condition. Is it the treatment itself, or is it like any kind of treating depression? So we have an active treatment control in this 3-arm study. So one group gets not group like as in group treatment, but one treatment assignment arm gets treatment as usual, as I said, enhanced. One group gets cognitive behavioral therapy as the method for treating depression with the adherence content. And the other group got information and supportive psychotherapy. So they were still getting a psychotherapy, also integrating adherence counseling via life steps, and assessed over 4, 8, and 12 months. What we did a priori is we compared the experimental intervention to each of the control groups separately. And what we found with the MEMS adherence, comparing CBT-AD to enhanced treatment as usual, we replicated the findings of the prior studies, which is generally that adherence improves in the treatment condition compared to the control group. And we found depression also improves let's see. Depression goes down, adherence goes up in the treatment group. Depression doesn't go down as much, adherence doesn't improve in the control group. So we found that. At post-treatment, we had lower depression ratings on the CGI and the MADRS, which were the clinically assessed ratings. These were the self-report ratings for depression, that is, and the MEMS adherence. And then we also found that in terms of maintaining their gains over time, we found that they were maintained compared to that control group on most outcomes. It didn't quite make it on the MADRS in terms of significance, but it did on the CESD, which is the self-report measure of depression, the clinically global rated impression for depression. But MADRS, the separation didn't continue, and MEMS stayed separate from treatment and control. But sadly enough, we did not find differences in the CBT-AD, the structured treatment of depression compared to information and supportive psychotherapy, which is a different way of approaching treating depression or, psychotherapy. That group that also had integrated adherence and depression components, we didn't see a difference between the experimental and that group on anything. We also didn't see any effects on viral load or CD4, but also the time of this study is when antiretroviral therapy got a lot more potent and a lot easier to do, which is amazing for the universe and not so good for our study because everybody, like 80% of the trial was virally suppressed at the follow-up. So it was really hard to see a difference. And we didn't select for virally unsuppressed people at the beginning. So that was kind of the penultimate trial. Now is the ultimate trial that we did, which was shifting over to Africa, where depression is also a major problem comorbid with depression. Depression comorbid with HIV or HIV comorbid with depression. Depression is still a big problem with HIV in Africa as well. This was a collaborative effort with the folks at Mass General, University of Cape Town, as well as a fabulous consultant, Dr. Simoni. Before the trial, the randomized trial, we did a pilot study where my colleague Lena Anderson trained some nurses in the intervention with our support and did an open phase trial at trying to get, so the issue here is that in Africa and globally in general, really there are not a lot of trained mental health practitioners compared to the need. It's tremendously bad. The rates of like psychiatrists, psychologists, and even, trained mental health counselors, there's just a very big shortage. So people are not getting treatment for mental health disorders. However, the cadre of available specialists that we determined by talking to the city of Cape Town and other stakeholders is that, you know, all clinics have nurses. And so not all clinics have peer counselors, not all peer clinics have adherence counselors, but all clinics have nurses. And so that would be the cadre consistently of potential people to deliver this intervention if we were going to take a task sharing approach. So task sharing meaning, because there aren't psychologists, psychiatrists, or, you know, not licensed, but like mental health counselors, could we task shift this to nurses or to someone to carry out the treatment of depression with adherence counseling integrated? So we trained 2 nurse interventionists in these trials, well, this trial and then another one, and it seems like it worked, you know, in the open pilot. Another thing that happens, you probably are aware, I know Jane is aware, that Wisepill adherence, when you monitor adherence with a device, an electronic device, there's something called the Hawthorne effect, that like adherence gets better, and it usually lasts for a little bit. So even though adherence here didn't like end improved, it probably, this 80% here was probably a bump up from their baseline. And usually the studies show that if there is a bump like that from monitoring alone, it usually lasts about two months. So in here, people were maintained above 80, which tends to be a pretty good cutoff for adherence. So after that pilot feasibility study, we also, I'm going to just talk about persistence in terms of if there's junior people on here. This trial also took, I think, 4 submissions. And I'm also going to say, like, of the work that I've done in my career, this trial that took 4 submissions is really probably the most successful of studies that I've done in terms of like the eventual impact too. So, so be persistent if you're passionate about an idea that you think the world needs in terms of advancing science. But in this one, we had a 2-arm randomized controlled trial, CBT as described compared to enhanced treatment as usual. And in this study, we were able to enroll people that were virally uncontrolled. So anyone with you had to have a detectable viral load to join the study. You also had to have failed your first-line antiretroviral therapy, like you had to have gotten antiretroviral therapy and failed it in order to be uncontrolled in this situation. It's not people that are newly diagnosed. From 4 primary clinics in Khayelitsha, South Africa. They had to have a major diagnosis of major depression. We again had trained nurses as interventionists. We randomized 163 people. They did a 4, 8, and 12-month follow-up, and they monitored their adherence with the Wisepill, which is a pill box that we get real-time data for into cell phone towers that goes to the server, and we can monitor, see at any time people's adherence. So our outcomes. This is from 0 to 18 weeks, the acute outcome, where what we did a censored and an uncensored, because when people weren't using the pill cap, we censored those individuals just to see the difference. But in both analyses, the censored and the uncensored, the adherence was significantly greater in the CBT-AD group compared to enhanced treatment as usual. The depression acute outcome, so that means pre to post, also saw superiority in the outcomes that we use. We use the Hamilton Depression Rating Scale and the CESD. In follow-up adherence, it was the difference between the treatment group and the control group stayed significantly different, with 24 percentage points higher adherence in CBT-AD compared to enhanced treatment as usual. And although you do, as I was mentioning, you do see a waning in the adherence over time, but the treatment group stayed superior. And then also follow-up depression superiority across our outcomes, that depression was better in the treatment group than the control group over time. Biomedical outcomes. So this is what makes this study, I think, kind of like, in my mind, next level, which is that we finally, of all those other studies, had not seen a viral load difference, but also in those other studies, we didn't select for detectable viral load. And in here, our a priori outcome was whether viral load was detectable at 12 months. And yes, we saw a difference with a 2.51 greater odds of having an undetectable viral load compared to those in enhanced treatment as usual. An exploratory outcome, just because the a priori was just at the 12-month outcome, but when we looked over the 3 follow-up time points, CBT-AD had a 3.54 greater odds, and then also continuous viral load was better in CBT-AD than in treatment as usual. We did not, now, I've been talking about CD4 a little bit in this talk. In this one, we didn't find a CD4 outcome. So I don't know what to, I just still don't know what to make of that. But another thing that we looked at was cost effectiveness. We had a excellent cost effectiveness collaborator, Ken Friedberg, and his team at Mass General and the Preventing AIDS Complications group. They have a microsimulation model where they use trial data to model the incremental cost effectiveness ratios. That's the ICERs, which is amount of money by quality of life adjusted years. And then the cost effectiveness standard that's used in these kinds of studies is about 5% of the per capita GDP. So in this case, it would be around $2,545 for every quality of life year. Would be the standard per the 2020 South Africa per capita GDP. And the circled thing here is what we found is that as the ICER, the cost effectiveness ratio, is a lot lower than $2,545. So, and we also did like a ton of different sensitivity analyses, raising the cost and lowering some of the parameters to points where it would be really in none of the simulations we ever really exceed with different parameters this kind of standard cutoff for cost effectiveness for this intervention. Okay, so those are the CBT trials. I did want to talk a little bit about studies that treat depression, but don't address adherence in the intervention itself, even if you're treating depression with an evidence-based approach. So this is a psychosocial trial that was done in the Adolescent Trials Network, comparing intervention for treating depression in adolescents with HIV to treatment as usual. And what you see, which is the pattern that you're about to see in the other studies I'm going to show, is that when you treat depression, you get results in depression, but you don't necessarily get results in the HIV outcomes if you don't also include HIV adherence content. Interestingly, the observational studies with antidepressants do go against what I just said, which is that when you look at retrospective medical record data, you do see that those with depression that's treated with antidepressants generally have better HIV adherence in these 2 studies, as well as this collaborative care study that I was part of at Mass General. But when you look at prospective trials, there's 3 of them that I know of here that I'm talking about. But when you look at prospective trials that involve prescribing antidepressants in people with HIV who have adherence problems, what you see in general is this is one directly observed antidepressant trial by David Bangsberg group. This is the High Tide study by Pine et al. This is the Slam Dunk study with Duke, UAB, and UNC using a collaborative care approach to treating depression. And you generally see that depression in these studies tends to improve when you treat depression, but no difference in antiretroviral therapy uptake, ART adherence, or viral suppression. In this one, same thing, no difference in adherence, viral suppression. Well, this one, I guess it wasn't, viral load wasn't reported, but no difference in adherence. And in this one, no difference in adherence or viral load. Okay, so we also have noted in these trials that I just mentioned that when people come in with depression and HIV, typically that's not the only problem that they have. And so we've been more recently looking at syndemics, intertwined psychosocial problems that affect health and health behavior. The most frequent studied syndemics have been in men who have sex with men, but it does involve like syndemic with each other, depression, substance use, childhood. Sorry, I'm just, whoops, moving my viewpoint so I can see. Intimate partner violence, and other studies use other kinds of like anxiety disorders, sexual compulsivity considered to make up a syndemic. And, you know, I did move to Miami 7-8 years ago. Miami's one of the highest HIV incidents of any US city, the highest prevalence rates. Depending on the year, some years we've been the actual highest. I think right now we're in 5th place or something. And it's also a very diverse breakdown in Miami of ethnic and cultural. It's a cultural melting pot here. In fact, it's the majority of individuals here, like I show right here, that non-Hispanic white, in terms of the ethnic breakdown in Miami, is only 16%. So what we tried to do is say, all right, well, let's say people come in with multiple different problems. You know, should we have to have a separate intervention for depression, a separate one for substance use, a separate one for, you know, whatever syndemic they have? So what we tried to do is just develop like a unified protocol that people would get a combination of motivational interviewing and CBT worksheets that would match the difficulties that they're having, but we would train, in this case, graduate students as counselors to deliver this intervention. And so it would basically be like I was saying about the adherence and depression, or the adherence component. It was basically like, let's try to treat with cognitive behavioral therapy whatever we see when people come in, but whatever we're going to do in this treatment, we're going to integrate adherence counseling with it. So we did do a small trial with, ended up getting 27 people that started and 24 that completed a 4-month follow-up, and 23 an 8-month follow-up. We did allow booster sessions. Sorry, in the South Africa study, we also allowed a few booster sessions. And in that, you know, we did see some, you know, it wasn't randomized, but people's viral loads did get better in terms of percentages of viral suppression and also just continuous viral load. Adherence, you know, this pattern of, again, I think this might be a little bit of a boost, but adherence generally, you know, improved a little bit per week while they were in the trial. And, oh, that was self-reported adherence, and this is the Wisepill adherence. Let's see. Oh yeah, this is the longer follow-up. Wisepill adherence did significantly decrease though from baseline to 8 months during the follow-up. So, which mostly happened during the follow-up. Let's see. These are, we tried to come up, this I wouldn't do again. If you're wanting to know about methodological studies for doing studies where not everybody has the same mental health disorder, it's hard to see a difference, but we tried to look at things that cut across whatever mental health problem you had, and that would be positive and negative affect, like how much joy, positive affect do you experience, negative affect being like, you know, depression or anxiety. And we did not see a change in positive affect. We did see a decrease in negative affect in the trial. And then also not a difference. So that was within when they were doing the weekly visits. And this is just at the major visits, baseline 8, 4, and 8, that we didn't see a difference. All right, we're kind of needing to wind down, but I will say that in terms of the example participants, again, I was talking at the beginning about like the 5% of individuals that aren't going to benefit from, in my mind, or I just don't think people are going to benefit from just minimal, I'd say, adherence interventions that don't address mental health. These are, and in this study, the only inclusion criteria was suppressed viral load. We didn't say you had to have a disorder or a syndemic or whatever. And every single person in the study, these are just some examples, but have just such complicated lives and so many things going on and so much of the stuff that we know about, but like whether it's substance use, whether it's incarceration history, whether it's childhood abuse history, whether it is just racism, homophobia, so, this person here, this transgender woman, sexually assaulted at age 30, instances of being attacked for her gender identity, including twice during the study, marijuana use, cocaine use, like daily marijuana use, cocaine use. She became adherent in the trial, but not suppressed. We lost contact at the 8-month follow-up. That's just one person. I mean, every story is in the study, every single person. When you look at the overall percentages of elevations in depression and stuff, you really don't get a picture of what each individual's experience is that they bring to this issue of trying to take care of themselves in the context of depression, mental health issues, as well as just structural barriers, which are much bigger in Miami than Boston. Okay, I've been saying this stuff as we go. General conclusions. So general conclusions. Mental health, substance use highly overlaps in those with HIV. It is exacerbated by social and structural challenges. I've been saying this over and over about the 90-95 goals. My contribution to the field, I think, is really that integrating treating mental health problems with health behavior change is the way to get improvements in both of those outcomes. If you do just treating the mental health problem, you'll only get mental health outcomes. If you do just the adherence component or health behavior change component in people with depression or mental health problems, you probably won't even get the proximal outcome of the health behavior change that's needed. We do need to do more cost effectiveness studies. We absolutely need more implementation and dissemination interventions, strategies that would get some of these kinds of, I'm going to say costly treatments, but we don't, in South Africa, it was cost effective, but we need to figure out ways that, in the universe, if you are a privileged white person with health insurance and depression and you don't have HIV, you are much more likely to get this type of cognitive behavioral therapy for, maybe 20, 30 sessions of treatment with a licensed provider. So, my public health colleagues are always like, make your interventions smaller, make them, digital, make it that, can't they just log on to the computer and have their depression treated? It's like, well, that's not what happens in, privileged populations. I just don't see it happening with people that also are dealing with HIV, which in general are also, a lot of different minoritized populations and such. That is where I will stop. Thank you very much for having me. And I stopped right on time. I was told 7:50, and that is what I did.